Hello, my name is Professor Tin Aung, and I'm from the Singapore National Eye Centre and the Singapore Eye Research Institute. My talk today is on imaging for angle closure. I have no relevant financial disclosures. Angle closure glaucoma is an important form of glaucoma worldwide, especially in Asia. The disease differs from open-angle glaucoma because it's primarily a disease of the anterior segment with closed angle, making the eye having high pressures and developing glaucoma subsequently. Thus, we need to make correct assessment of angle closure, and for that, we can use either clinical methods or imaging. We can also use imaging to look at the mechanisms or subtypes of angle closure glaucoma. When we look at the eye and assess the angle, we use gonioscopy as the clinical method, and this relies on using a lens to visualize the angle structures. And in this method, we are visualizing the angle to see whether there's apposition of the iris to the trabecular meshwork, which is the sign of angle closure. Although gonioscopy should be performed for all patients, we also know that many ophthalmologists are not familiar or not confident of doing gonioscopy, and so this procedure is not done routinely in many patients. Gonioscopy is also a very subjective assessment and is variable according to the observer. It varies with the lighting conditions used as well as the lenses that you use to place on the eye. Finally, many people have different ways of recording their gonioscopy findings, and you need good training to perform gonioscopy well. Let's move on now to different methods of anterior segment imaging. And here you can divide them into cross-sectional angle imaging or 360 degrees imaging. The earlier method of looking at the angles relied on using ultrasound B-scan systems, and this allows viewing and acquisition of the angles in real time with a frequency of 50 megahertz. UPM is a good way of imaging the angles and is also able to visualize structures behind the iris, such as the ciliary body, which is useful for diagnosis of plateau iris. The disadvantages of UPM include a limited field of view, being a contact procedure, requiring a skilled operator, and also takes a relatively long time. We move on now to OCT, or optical coherence tomography, and anterior segment OCT has been around for several years. With this method, you obtain a cross-sectional image of the anterior segment, as you can see in this picture. The advantage of anterior segment OCT is the good spatial resolution, it's non-contact, performed with the patient sitting up with rapid image acquisition. When you see the anterior segment OCT image, there are two ways of analyzing the image. One is by subjective analysis by the observer to determine if there's angle closure or not, and secondly, quantitative analysis using measurements. For subjective analysis, again, we're trying to look for apposition between the iris and angle structures, particularly the trabecular meshwork. So what you need to do is you need to first look for the scleral spur, which is the landmark defined by a change in curvature of the inner surface of the cornea and the inner surface of the sclera. And where that change in curvature occurs is the scleral spur. The scleral spur is a landmark for the trabecular meshwork, which lies just anterior to the scleral spur. And here you can see on the histology image the scleral spur in blue and the trabecular meshwork in red. So when you determine subjectively if there's angle closure, you first look by following the inner curvature of the cornea to the sclera, and where they meet is the scleral spur. And if there's contact of the iris anterior to the scleral spur, you assume that there's the contact between the iris and the trabecular meshwork, and there's angle closure. Here's an example where there's no contact of the iris anterior to the scleral spur, and this is an open angle. And here's another example where if you follow the inner curvature of the cornea and sclera, you will find the scleral spur, and there's contact of the iris anterior to the scleral spur, and this denotes angle closure. You can also make measurements of the angle, again relative to the scleral spur, usually 500 microns away from the scleral spur, and this is because the trabecular meshwork lies within 500 microns of the scleral spur. The main disadvantage of the anterior segment OCT is that you're unable to visualize the trabecular meshwork in most cases. Also, you cannot visualize deeper structures such as ciliary body. You're limited to one cross-section of the image at any one time. You're unable to indent the eye to look for peripheral anterior synechia. And often there are limitations in the angle assessment software, as well as to define where the scleral spur location can be. Here's an example of an image where it's difficult to determine where the scleral spur lies exactly, as there's no clear change in curvature between the cornea and the sclera. And depending on where you think the scleral spur lies, it could show either either angle closure or open angles. In Singapore, we've been interested in looking at automated ways of grading anterior segment OCT images. And instead of using subjective analysis by an observer, we developed software that can automatically grade the angle using machine learning. And here's an example where with this software, you can determine in green showing open angles and in red showing angle closure. Similarly, we also make measurements of the angle relative to the scleral spur, and this can be done automatically. We move on now to spectral domain OCT or high definition OCT, and this is a slightly higher resolution technology with faster scanning speed. Here's an example of a high resolution image showing the trabecular meshwork, the Schwa-based line, as well as the scleral spur. There's another image showing a patient with high resolution contact of the iris anterior to scleral spur where the trabecular meshwork lies. Another example here of peripheral anterior synechia. The serous anterior segment OCT is a commonly used device, and this device relies on using external adapters to a posterior segment retinal OCT, and then this adapter will then change the magnification as well as the scanning interface to look at the anterior segment. And there's some image processing that's performed. You can see here the remove shadow image that is formed by the reflection of the image. And that's why you may find sometimes two bands in the cornea. The serous anterior segment OCT, you're also able to rotate the axis of your scanning. And here's a comparison between a serous image and compared to Visante image. You can see really not much difference in terms of quality. As also, a serous has a wide angle-to-angle scan showing the whole anterior chamber but closer to the iris and lens surface. And here's another example of a high definition scan showing you again in much greater magnification the angle structures and the iris. Lately, newer OCTs have been developed, such as the swept source OCT by Cassier Tomei. This device produces cross-sectional imaging in 360 degrees, as you can see in this example, where you can see the eye moving around in 360 degrees and all the angle structures visible. A scan that I particularly use is this scan, where you can see in the bottom left an arrow moving around showing you multiple images of the eye in 360 degrees. This video actually consists of 128 slices of the anterior segment. As you can see on the top right, as the arrow goes around, you're able to obtain 128 images of the eye in 360 degrees. You get a composite of 128 scans showing you 256 angle images. With this Cassier device, you are also able to assess iridotrabecular contact in 360 degrees by plotting out the location of the scleral spur. And this method, however, is a little bit tedious, where you have to mark out on several serous images the scleral spur location as well as the level of contact between the iris and the angle wall anterior to the scleral spur. In Singapore, we've also developed a 360-degree angle assessment tool which simultaneously grades all 128 scans of the anterior segment of the serous OCT and then comes up with the composite results in 360 degrees. So what this software does is that it grades each image in turn, open or closed, and then summarizes all these findings into the figure on the bottom, where you can see the areas in red where the angle closure lies, and on the bottom right, the cumulative amount of angle closure or open angles. The catheter is also able to image peripheral anterior synechia, as in this example. And in this study that we published several years ago, we could see that you can actually document changes in the peripheral anterior synechia extent after surgery. Here's an example of a patient before surgery and one after surgery, showing you removal of the peripheral anterior synechia. Lately, there's also a new device called the hyperparallel OCT or SciLight, and again produces high-resolution scans of the angle with a faster scanning protocol. Finally, before I end, I'd like to mention a few methods of looking at the angle using photographic methods. For example, there's a new automated 360-degree angle photography method by NIDAC, which basically takes a picture of the angle in 360 degrees, and you can see here an image where they unroll the angle images in 360 degrees to see a continuous frame of the angle. And studies have shown that this is a quick method of obtaining angle images of the eye. Here's further examples here of angle images obtained by this device. In Singapore, we're also developing a new device called the Gonio Pen, which is a much lower cost method of imaging the angle. This is a probe that's attached to a slit lamp, and you can hold it against the eye to produce images of the angle, as you can see here on the bottom. And this is a low contact method of imaging the angle using photographic methods. So in summary today, I've given you an overview of the role of angle closure imaging to make the diagnosis and for documenting the angle structures. Finally, I'd like to mention a few words about how imaging can also produce new insights into angle closure pathogenesis. For example, using imaging, we've identified risk factors such as iris thickness, anterior chamber width, area and volume, and lens vault. And this method, if you combine these methods with imaging methods, you can find that you're able to detect angle closure with an AUC of 0.8 to 0.9. Here are examples of some of these imaging modalities. Here you can see the iris thickness as well as iris cross-sectional area. And this you can see that the thicker the peripheral iris, the higher the risk of angle closure developing. Iris thickness, curvature and area have been found to be independently associated with angle closure risk. Another risk factor is anterior chamber width. So it's not only the depth of the anterior chamber that's important, it's also the width of the anterior chamber. The smaller the anterior chamber, the more crowded the eye and the higher risk of angle closure. And similarly, a smaller anterior chamber area and volume are associated with angle closure risk. Finally, a risk factor called the lens vault, which is the part of the lens anterior to a line joining the two scleral spurs. And this represents the part of the lens that's jutting into the anterior chamber. The lens vault is different from the lens thickness and lens position. All these studies indicate that angle closure glaucoma is not a homogeneous disease. In some patients, there are some factors that are more important than others. For example, there could be the thick iris. In others, it could be due to a small anterior chamber. And in others, it could be a large lens vault. Thus, you need to look at angle closure in your patient and decide which is the most important anatomical factor. We've also studied the question of whether there are subgroups of angle closure based on anatomical factors. In this study we published in 2013, we found there are actually 3 subgroups of angle closure. One with a thick iris, secondly, one with a large lens vault and small anterior chamber, and thirdly, a mixed mechanism group. This was published in this paper in 2013. We're also looking at new methods of classifying the angle closure risk factors using anterior chamber imaging. And here you can see here a paper where we combine 6 anterior segment OCT parameters and to see whether you could improve the risk detecting the risk for angle closure. And this study we published last year, we found that if you combine these parameters, you can get an AUC of almost 0.95. And this is a newer, perhaps in the future, could be a very good method of determining angle closure based on a single scan. Finally, we also looked at different deep learning methods to see whether there are better methods of detecting angle closure using deep learning compared to angle analysis. And we found, for example, in this study, that deep learning also produces a very good AUC performance of 0.90. So in summary, I've mentioned to you different mechanisms involved in angle closure risk, including pupil block. We also can look at differences in treatment after laser iridotomy. We can use imaging to document treatment after lens extraction, and also mechanisms such as plateau iris using a UBM, and variations in iris anatomy, as well as the effect of treatments like iridoplasty for plateau iris. As I mentioned to you earlier, the lens vault is also important, and you can look at the lens component and look at the objectives, the effect of you removing the lens for angle closure opening. So in summary, there are many objective methods of imaging the angle and anterior segment. Many of these are easy to perform, and you need both qualitative and quantitative analysis. There are different advantages and disadvantages associated with each method. The future of angle imaging will rely on 360-degree circumferential angle imaging with automated angle analysis. And there's also the potential of using Gaudian photography to document the angle using photographic methods. I'd like to acknowledge here my collaborators from Singapore, as well as others from around the world. Thank you for your attention.